Dear pure urology viewers, good evening one and all. Today topic is minimally invasive surgeries for prostate. The prostate surgery actually has a treatment as swinging up and down, but what constantly remained is TURP. Enucleation has come recently way forward because large glands, it is still the better treatment. Bleeding is less. Complete removal of the prostate can be done. Thulium fiber laser, thulium YAG laser, holmium laser YAG. All the three are possible. But there are certain patients where patients are unfit for surgery, spinal anesthesia, or bleeding, not able to stop anticoagulants. Two treatments have come very much in limelight from Western countries to India are Urolift and Rezum. The mechanism of action is totally different. Logically, both appear illogical, but somehow a lot of people are using because it is very easily done, both of them. If somebody has done both, I have not done both. So if somebody has done both, they can give some idea, though everybody is at primitive level. One such urologist is Dr. Ashish Saini, my close friend from Delhi. His focus from beginning is on the prostate, apart from all other surgeries like laparoscopy, stone. He is more known for the prostate surgery, particularly for thulium fiber laser, particularly for various settings and doing all types of glands with all types of methods. Naturally, he will be getting cases for the other way around also. So taking his experience into consideration, I thought he will compare both, though it is too early for anybody to give series, but initial 10 cases comparison, 15 cases comparison, it is possible for him. So to start with, I will read about briefly about the Ashish Saini. So today topic is video-based surgical presentation on Rezum and Urolift pros and cons by Dr. Ashish Saini. Both are procedures which are driven and done in Western countries. They say that they are promising results. Talk about that, Dr. Ashish Kumar Saini is senior urologist. Previously, he was also in Pure. So now again for the juniors, he is MBBS gold medalist, MS, MCH gold medalist, urologist, AIMS, DNB urology. So current position, director and founder of Excel Advanced Urology Center, Greater Kailash 1. Ex-Director and Head of Department, Primus Super Speciality Hospital, Chanukyapuri, New Delhi. Ex-Assistant Professor of Urology, All India Institute of Medical Sciences, New Delhi. Area of his interest, trained in doing all kinds of complex urology surgeries like uro-oncology, reconstructive urology, robotic surgery. Performing more than 6,000 urological surgeries, 27 PubMed Index journals. His hobby is cycling, very important. Ultra cyclist and first urologist in world to complete PPB 2023 Paris, Brest, Paris, 1,200 kilometer cycling with 11,500 meters of elevation. Membership Professional Society, is member of USA, Narjone, Urological Association of Asia, European Urology Association. His faculty during AIMS period selected for International Forum for Young Urologists, Beijing, China, 2012. Japanese Urology Association following fellowship in renal transplant in 2015 under Professor Nakagawa, Kagoshima, Japan. Reviewer of Indian Journal of Urology, Urology Internationalist and International Journal of Urology, Urological Associations of Asia, Urology, Youth Fellow 2016 at Singapore. With his good academic background and private practice background, let us listen from him, both Urolift and the Rezum. Over to you, Ashish. Thank you very much for accepting the notice, the invitation for short notice. Thank you. Over to you. Ashish is joining. For those who he has joined, for those who are using, you can share in the view box. Okay, Saini? Unmute. Yeah. Yeah, your screen is shared. Fine.
Okay. So today we'll be talking about the the clinical and the real world data. The data is actually more from the Western world. I'll be showing some of the videos which we have done and what to take from that. So basically, thing from the beginning. Yeah. So we'll be talking about Urolift versus Rezum. What are the pros and cons? And if you look at the historical overview of the BPH treatment, in 1926, it was when the first URP was performed in US. And that is the first time where we had the first flight, as well as the T4 model was launched. So it has been there for so many years. The problem is that uh, if you look at the long-term effect of medical therapy, there are marginal improvement with drug therapy in patients of prostate, and all of these drugs have a lot of side effects. These side effects may not be pertinent for some population, but looking at the newer, younger population which we are seeing, there are a lot of ejaculatory dysfunction, erectile dysfunction, and other certain uh, problems in form of lightheadedness, fatigue, and therefore it has been found that the adherence to monotherapy is less than one third. So at 1 year overall, there will be only 30% of patients will be actually taking the medicines. And this is the data from the West. In So the other question is that can we delay the treatment, and can these patients who do not want to take medical therapy also, or have a side effect of medical therapy and who do not wish to undergo a TURP, can they be just put on watchful waiting? So it has been found that if you delay the surgeries in such patients, from a healthy bladder, what you're going to get is a bladder which has been permanently damaged. And this is something which has been now come under focus, because the bladder, once it is damaged, because what we are seeing is that the patients are on these alpha blockers for more than 10-15 years, and nobody is looking at what is happening to the bladder, and therefore these bladders initially they are hypertonic, overactive, and then they become underactive. So there is a subset of patients where a minimally invasive therapy is actually a bridge between the traditional TURP or an enucleation versus medical therapy. So it has been found that since so many are discontinuing medical therapy and very few are actually seeking surgery, there is an unmet need of a larger subsection of patients who may actually want to have a less invasive treatment in form of a mist therapy. Now, looking at the men's perception of importance when considering a minimally invasive therapy, the most important thing which they are considering is if there is no post-op catheter. So 10 is the most important. And then the other are rapid relief of the symptoms, a rapid recovery, a minimum downtime, and also which causes preservation of the sexual functions. So these are the parameters which when men were asked the questions. So the only question I would ask is that how many urologists will actually want to undergo a TURP themselves or a enucleation of the prostate themselves? The answer would be very clear. So what urologists want is a rapid relief with minimum side effects. It can be ambulatory and it's a straightforward procedure. The HOLEPs or enucleations have never been popular till now because there is a very big learning curve, and therefore these procedures have come which are reliable and reproducible. Urolift may still be somewhat technically demanding when we are putting how the implants need to be put, but Rezum is a very straightforward procedure. And that's the reason where enucleation is not that much popular. The Rezum and Urolifts are the one which are very popular. What is the, so these are the three bigger studies which are done on Urolift. One is the lift study, then there is a real world retrospective registry study, and then the third is a healthcare and utilization analysis. And they found that these studies were the one after which the FDA approved this treatment for patients. And there was a significant and a sustained reduction in the IPSS score in these patients at, so there was a 10-point reduction at 12 months. So that is also important, that when we are doing a Urolift or a Rezum, the reduction in IPSS scores are not going to occur in the first month of the therapy. And usually these patients will take 4 to 6 weeks for showing the response. And then after 3 months, there is a marked response because of the remodeling of the prostate. And the Urolift has also achieved consistent results in patients who have an obstructive medial lobe. So recently I did 2 patients who had an obstructive medial lobe, and both of them, they were not voiding before. One was on a catheter and now he is voiding. So it can be done. And the patients are shown to recover more quickly and they are satisfied sooner versus the TURP patient. TURP catches up. So you look at the recovery rate. So usually at 6 months or at 9 months, it may be similar, but then in the initial 6 to 9 months, it is the posterior lift which is being shown to be better than a TURP in form of recovery. The catheter dependence and the interventions or the retention. It has been found that if you look at the baseline versus the pulsar study, it was found that the data is comparable to TURP. So what are the mechanism of action? So what is happening is that the action is almost opposite to what we are thinking. When we are doing an enucleation, we are actually enucleating from below and we are making a floor as well as the roof, and then we join everything. In this case, what we are doing is we are trying to make an anterior channel. And they say that it is the anterior channel from which the catheter goes inside. So basically nothing is done on the from 3 to 9 o'clock. Everything is done from 9 to 3. So basically what you are doing is that you are putting the clips at 10 o'clock, at 2 o'clock and 10 o'clock. And basically you are actually opening it like a shamiana. And instead of the MR, you can even look at these clips. I have been doing truss in these patients post surgery and an ultrasound, and you can actually see where the clips are. So initially what happens is that there is a tissue compression because of the device. Then there is decreased blood flow, following which there is lobular atrophy. And finally, there is scarring and tissue remodeling. And these will usually start after a period of 3 to 6 months. Supposingly, if somebody removes the implant after 3 to 6 months, or even if you pull it out after a Urolift, it is not going that the prostates are going to fall back. They are at that point of time, they have already scarred and they will be there. So even if you take out the implant after 6 months, it doesn't matter. So now the most important thing, which was actually maybe a marketing tool, but this is what we are seeing, that there is no incidence of de novo sustained ejaculatory or erectile dysfunction in patients of Urolift. So in my subset of patients, a younger patient who doesn't want to take an alpha blocker or who has a side effect because of an alpha blocker will be offered a Urolift device or a Rezum, depending upon what he wants to do. Because here our principal thing is to preserve the ejaculation in erection. And then there is a second subset of patient where he is not a good surgical candidate. That patient may be offered a similar treatment. And we will be discussing about the case scenarios in the coming. So basically, this is what it was found that in all these patients, it was posterior lift which significantly improved sexual satisfaction throughout the 4 years, and they have a better uh, outcome compared from all of the medicines or the placebo combined. Now looking at the overall procedural complications. If you look at the procedural complications of these systems, this is the data where the Rezum was found to have much more higher complications in form of dysuria, in form of recatheterization rates, versus the Urolift has the least in this study. the rate of surgical retreatment through 1 year was found to be 5.9. So it is similar to TURP. There was one study we'll be talking about where it says that it was 23%, and we'll be then segmenting it again and looking at why it happened to be 23%. But usually, the retreatment rate of all these therapies is similar. Looking at the 5-year surgical retreatment rate. So most of the time, what I am pounding is that nowadays the people may be negatively counseled, and they have been said that if you do a posterior lift procedure or if you do a Rezum procedure, you may underwent a retreatment. Yes, a retreatment is there, but the retreatment was also there with the green light as well as a TURP. It is the least with an enucleation of the prostate. Now, how do you redefine retreatment rate? So are you doing, if there is a surgical retreatment, there is a surgical intervention or complication in form of a clot removal or an endoscopic dilatation, or there is a medical intervention. So if you combine everything, it was found that the Urolift system had a retreatment rate of 33.6%. So when it was combined with the TURP also had a similar thing. So you have to look into whether we are talking about medical intervention or we are talking about a surgical retreatment or a surgical intervention. So if all of them are combined, the Urolift has a similar incidence as a TURP. So now we'll be talking about Urolift versus Rezum. And this is a 64-year-old sexually active male with low urinary tract symptom. He's a hotelier and he came to me. And this is basically, we planned this. So in all these patients, we tend to do a flexible scopy to look into where we'll be putting our implants. And then this is the device. So device is actually rotated inside the bladder. And then as we are coming out, we will be putting the first implant around 2 centimeters from the bladder neck. And it is at 2 o'clock position. And then we will be looking at the white line. So you can see that this is the white line. Once you have seen this white line, then you fire the implant. So now the implant has been fired, and then you again go into the midline and then you go inside. This patient actually had a knee replacement done, and then he had a retention of urine, and we did a Urolift in this patient, and he's voiding well. We recently had a 3-month follow-up, and he was happy with the treatment. So most important is that we are creating an anterior channel. Nothing is done posteriorly. And you look into the white line. So this is the white line. Very important to look into the white line, and then you break it. If you are too higher up anteriorly, you may lose the implant. So this is how it is created. And this is how an implant is being seen. So this is the implant, and then there will be a mucosa over this implant after a. So then the second implant is placed. We have to look at where the veru is, and 1 or 2 centimeter proximal to the veru is the second implant. Again, we see the white line, and then we fire the device. So this is how you are actually creating an anterior channel and doing the thing. Now coming over to the patient of Rezum. So in this patient, he had a median lobe with a high bladder neck, and so this is the Rezum where so there is a difference between Rezum and the tuna therapy which came. So this has a conventional mechanism of heat, and therefore there is a uniform spread. So there is a 9-second treatment cycle, and almost 20 cycles can be given. So you can actually treat a prostate of almost 100, 120. Usually they say that it should be around 80, 90 grams, not more than that. So this is when you have put the water vapor inside, there will be bulging of the tissue. And the only downside which I found was that we need to keep the catheter depending upon the treatment cycles. So if the treatment cycle is there for like there are 5 treatment cycles, then you have to put the catheter for 5 days. If there are 10 treatment cycle, then you put it for 10 days. So that is a issue. If the patient is has to be counseled regarding that. So for all the patients where I've done them, the patients have themselves chosen a Rezum therapy, and then we have done it. One can see that this is how the vapors are going inside, and one can see the blanching effect here. This patient also came after a period of 3 months, and he is doing very well. He's happy that he wanted to do the Rezum procedure. So I think the patient counseling is very important when we are offering this treatment. And so this treatment is not for the masses, it is for subset of class of patients who can actually afford it. And secondly, those who need it. So in this, because the medial lobe was there, so we did on both the sides. Usually they say that you do one treatment for the medial lobe, but in this case we did 3 treatments for the medial lobe. And so the total treatment time was around 36. So the 4 treatments were done, 2 to the medial lobe and 2 to the lateral lobes. And the only thing is that once you have completed this procedure, it feels that you haven't done anything. So that white channel which is seen on the left side in Urolift is not seen in Rezum. And so this is the mechanism where we talk that we place implants. In Rezum, we are doing steam-induced tissue necrosis. So there is a thermal energy in Rezum. And the time to this obstruction is immediate in Urolift versus it takes 1 to 2 months, depending upon how the tissue is going to resolve. The initial 4 weeks are troublesome for these patients, so they need to be counseled. And looking at the clinical evidence, and so these are the publications of both the systems. And it has been found that the maximum prostate size for Urolift is 100. I haven't gone beyond 70 grams till now. And Rezum, they say that it's around 80 cc, but the people are saying that you can do more than 100, but 80 cc is what it was there. And obstructive medial lobes should not be done initially when you are doing your 10 cases. While in Rezum, it doesn't matter. If you have an obstructing lobe, it can be done. Now the durability of this study. Now what happened was that this is most commonly talked about, that if you look at the durability, it is more with Rezum. But the thing was that 22% of these patients were lost to follow-up and they withdrew the consent. Therefore, these patients were not taken into consideration. And the loss to follow was 12%. And therefore, this figure may be similar in both the cases. And the return to medication would be around 4 years or 5 years. So what you are looking at is a procedure which is going to be there working for you for 4-5 years. And then one can do a retreatment. Looking at the catheterization, the real world catheterization in my patients I have done in Urolift, the catheterization from 2 to 4 days, 4 days for patients who are in retention, and 1 day for a patient where we are doing it. So next day the catheter is removed. And the mean duration is usually around 5 days, 5 to 7 days, depending upon the treatment cycle. So the incidence of UTI is somewhat more in Rezum. The incidence of sepsis and strictures have not been reported. So this is also very important, that since you are not doing anything with the urethra, you are going with a very small sheath. So basically what we are using a 21 sheath for doing a Urolift or a Rezum. Rezum is much more lesser than the 21. It is almost 16 French. So therefore the stricture rate may be less. The stricture rate may be more in Rezum because of the thermal energy. And in the real world scenario, it was around 3.9%, while it was 0.2% in Urolift. And none of these patients were found to have erectile dysfunction, while in Rezum, the real world data of ejaculatory dysfunction was almost 41.8%. And that is something which needs to be seen. So this was the study design. And what was there was that if you look at the randomized control trial versus a sham treatment versus a crossover versus a per protocol treatment. And then this is important, an intent to treat. So the intent to treat is the analysis that includes all patients originally randomized to treatment. If the patient deviates from the protocol or are lost to follow-up, the last value is typically carried forward. And this was not carried forward in most of the Rezum trials. So this is a randomized, this is a sham treatment, this is a crossover, and then this is the intent to treat analysis. And it was found that the left 5-year results have all these versus Rezum. The intent to treat analysis was not taken forward, and therefore the data may be skewed. Looking at intent to treat protocol, there is no significant effect from the missing data, while there is differences in the surgical retreatment and return to medication in these patients were not discussed in the study, and therefore that 5-year crossover thing may be an issue. Looking at retreatment rate, the retreatment rate is almost to the tune of 22.2% in Rezum versus 12.9% in the LIFT study. And if you look at the 5-year system relief, then it has been found that it has been consistent. The IPSS scores, once they become all right, they are consistently there for almost 5 years. So in conclusion, I would say that it is an effective alternative therapy where we are not cutting anything, we are not heating anything, we are not removing a prostatic tissue. So it is truly minimally invasive. The only thing is we are putting in a catheter. So there is another thing which is coming up, and that is known as the ITND device, the implantable nitinol device by Olympus, and we'll be doing those initial cases in the month of September. And that's the only device where the catheter is not required because you can't put a catheter. So that may be truly minimally invasive treatment. So these treatments are there to stay, and there is a lot of area, lot of unmet need of patients which needs to be seen, and it's need to be addressed by doing these procedures. And if you look at the amount of data which has come, almost 4.5 lakh treatments have been treated, and therefore I think that this is what my conclusion would be, that there are two subset of patients. One is a patient who is basically someone who is actually sexually active and he doesn't want to take medical treatment or doesn't want to start medicine. So we have patients who do not even want to start medicine and they want to go for a procedure like this. And the second would be a patient who is not a good surgical candidate, and in those patients where we can do this procedure under minimal sedation. So in my experience, I have done it in almost all these patients. The only thing is that where the catheter has been there, or the patients who have acute urinary retention, there they will become catheter free, but they are not going to be super voiders like the patients who underwent a through flap or a pull-up. And that needs to be counseled right from the beginning when we are offering this treatment. Thank you for your patient hearing, and if there is anything, I'll be able to answer it.
Fantastic. I don't know where you got the data and you nicely compiled. If you have compiled yourself, great effort.
Thank you.
Great effort, appreciated. Now, question is, whatever in your patients, what is the condition where patient is unfit for TURP?
Sir, like there is a patient who underwent a knee replacement therapy. I'll give two real world examples in my case.
Yeah.
A patient who just underwent a knee replacement therapy. After the knee replacement, he was found to have retention. He was all right. The catheter-free trial failed. Now this patient doesn't want to undergo a TURP or HOLAP. He said, I already had a big surgery done. I don't want. Can you do something minimally invasive for me? So that is a subset of patient where we can do he is fit for anesthesia, but he doesn't want to undergo a second major procedure. Second patient is, so we did that. Second patient was 84 years old, ex-CMO, very fit marathoner. He had a recent dementia. After the dementia, he underwent a treatment for his eyes, and they did a short GA, and after that, his symptoms worsened. That patient attendant do not want to undergo a second treatment. So this is another subset of patients where an early intervention may be required.
These
And
two
they do not
patients
want
are patient choice based decision.
patient choice. The other thing is, sir, the fact is that now the anesthesia has become so good that we can actually do any procedure for 30 minutes. The thing is that there are certain subset of patients who have an ejaculatory function around 20-25%. These patients, in such one patient, we did it under local anesthesia with a very mild sedation. And in local anesthesia, what happens is that when you are firing the Urolift device, there is a sound. And that sound can give a startle response. So in that case, we need to, like, as we teach in the prostate biopsy, that this sound is going to come. So you can just tell them that this is how you are going to feel it. So once you have shown them that this is the sound which this device makes, they will not move the leg. So that is what I have found in one of the cases. In US, what they do is that they give them the masking headphones, that they do not hear to that sound. Truly minimally invasive is, as I said, that IT-ND device is there, which is going to be launched in September. And that would be something where we do not need anything. We just put in the device and it opens up in the prostate. It causes a Mercedes-Benz incision, and then after 7 days, we remove the device. The only thing is that how many days it is going to work, we really don't know. But the data from US is there, and we will see how things are moving in that direction. So usually in my patients where we have done it, it is not the anesthesia risk, because I'm having a single center which do not have an ICU or something like that. Those patients are there. Our patients are basically inclined to get this surgery done. So we do not counsel them. They themselves have been counseled. They have read about it, and they were reading about it in the US, and now they say that now it is available in India. So can you do it or not? So I think that is what is there, because the therapy is costly and the results are not predictable. If the patient has already chosen the therapy, he knows what the outcome are going to be, and therefore he is happy with his choices. So basically it is a choice which we have made. So instead of being a super voider, he will be voiding somewhat less, but his ejaculation and erections will be okay. So there are two subset of patients. You need to ask them whether they want to sleep in the night, or they want to have sex. So then you make your choice.
Okay. Well, both of the procedures, it looks like more than 2 lakhs will be the cost minimum.
Yeah. So basically one clip is almost 1,000 US dollars plus taxes. This is what is being printed on the, and so minimally 2 clips are required. In Rezum, basically the cost does not escalate, but in Urolift it escalates depending upon the implants.
Do you think that in future, if they all come like in RIRS, they all come less than 50,000, probably this is a game changer? Once
Sir,
the companies earn the basic money, they'll reduce the cost. Like access sheet was 12,000, now it is 6,000. Flexible access sheet. Everybody is using. Once upon a time, scope was 14 lakhs, then 7 lakhs, then 5 lakhs, then 4 lakhs, then it is 70,000, 50,000. Now it is 35,000 scope is also there. Flexible scope.
I think, sir, the technology as it is, when it is going to be like, even for robotics, one can see from XI to Mantra. So now everything would be laparoscopy may not be there, robotics will be there for everybody. So I think that will be the way forward. Maybe some Indians, they also look into the implant and they devise something like that.
So if the cost is less than 50,000, do you think that your heart towards enucleation will shift to Urolift?
No, basically,
Honestly.
no, I still believe enucleation is a very good surgery where the primary reason for doing would be a very severe obstructed flow. So if the patient wants to have a very good flow and a very long term कि एक surgery करानी है मुझे, I want one surgery for my life, I would still say that enucleation is the one which I am going to offer you.
How many of the patients after 60 years are going to ask about ejaculation in India? Honestly.
Sir, yes, in my
out of 100.
Sir, almost 40% is what I am seeing now. Almost 40%.
I don't see
So
that.
basically, sir, it depends upon the practice. It also depends upon what type of patients are coming. Now, sometime I am amazed that an 80 plus guy is asking for it.
He's
Not
asking
60.
for sex or he's asking for erection, he's asking for ejaculation. What
No,
you are?
he's asking for erections only, sir. Ejaculation per se is something which we are not asking. The fact is this, that the retrograde ejaculation is something which is not being even told to the patient when an alpha blocker is started.
Yeah.
Majority of the time. So they are startled by that. So once they become, see, it is all about awareness. We never used to even ask about erections. After erections, we are now talking about ejaculation also. So it is how the people are evolving.
Did you do any patients young age less than 40 years? Any of these
Sir,
procedures?
I have done, sir, it is not indicated till now. Even 45. See, we are doing a study on Urolift at our center. So the minimum age criteria is 50, but I did in one patient who was 45. He had a Qmax of around 4.5 ml only and had alpha blockers for almost 3 years. So yes, in younger patients, it is still not indicated. The only thing which is indicated in a younger patient is an ITI-ND device, which I have talked about. They are done for younger patients. It is FDA approved.
Have you ever tried bladder neck incision with laser under local anesthesia?
Not under local anesthesia.
Try karo and let me know, because you have a lot of cases. Before being anesthesia, you try and then after that you give anesthesia. Whether the pain comes to patient or not, you let me know. It is actually painless procedure if you do with laser.
But actually, sir, putting a resectoscope sheath, which is 24 French.
You have to put the same thing for these two procedures also.
No, in this procedure, we are putting, sir, in this.
Urolift, what is the size of the sheath? It is much bigger.
No, it is 20 French, sir.
What about the Rezum?
Sir, Rezum, we do not put anything. Rezum has a device. So the device. So that device is 15 French. So it is very thin. That way, I think the urethral trauma and urethral strictures, because we are there for just 5 to 10 minutes only. So that makes a sense
that intervention procedure is one thing, but initial urethra, if it is small, even if you put for 1 minute, 2 minutes, trauma can occur. Smaller size is better. Now, what is the size enucleation you are doing now? 22 or 18 or 19 or 24 only?
No, sir, I have 26.
26. So 26. So it's actually last questions. If you, how much confident you are, I don't know, I'm not able to convince myself that if fails, what will happen? If fails, what will happen? If fails, what will happen for 3 lakhs, 2 lakhs money? How will I convince? I have to do free of cost URP in my hospital because he will be roaming behind me. So do you have in your mind that if he gets irritative symptoms and it altogether, if he doesn't void, especially in Rezum, where swelling can occur in the post of day 1, and people say 4 weeks may be required. 4 weeks, do the patient accept in Delhi for catheterization?
Sir, the catheter is not for 4 weeks. The catheterization is for 1 week only. And 1 week, usually we tell them, that is very important, that you need to tell them that 1 week will be catheter and the initial 3 to 4 weeks will be very traumatic in form of pain. If the patient is very much convinced. So I did it in one of the pediatrician. He wanted to do a Rezum therapy in Middle East. And he said that I cannot take alpha blocker, tamsulosin, alfuzosin, anything. I have, whenever I take, I have a fall. He had a median lobe, a large median lobe. So it was not a floppy median lobe. So only Rezum could have been done. So it is a very much selective patient. It cannot be offered to a patient where I want to do a through flap and I'll say, no, you can do a Rezum. That will be a wrong thing to do. So patient selection would be the most important thing.
Are you
Otherwise,
doing TURPs? Are you doing TURP or not? Forgotten.
No, I haven't forgotten it, but I'm not doing it. I haven't done a TURP in the past 4 years now.
No TURP.
No, sir. I will offer a enucleation to all my patients. If he is not able to pay for enucleation, I will still do it.
You'll still do it.
I'll still do it.
And what is a foreign body effect in the prostate infection? Somebody is asking, prostatic abscess, can it occur with Urolift? I don't think so, but
No,
is it possible?
sir, a prostatic abscess can actually occur with a Rezum therapy if it has an active UTI, because you are actually putting steam inside, and it can occur even in a Urolift. So the only contraindication for a Urolift would be a raised in PSA and an active UTI. So it has to be, the urine has to be sterile. If the patient is showing you the symptoms of dysuria, or you are looking at a patient who had a history of prostatitis, I will never do these procedures in these patients, because they will be.
So urine culture sterility is also a little concern in this, especially Rezum.
Yes. So in Rezum, sir, if the patient has an active UTI or a history of UTI, you should not do these procedures.
Of course.
Yeah.
So if you go into the ejaculation per se, bladder neck closure is not important for ejaculation.
So that was a very old concept. Bladder neck has nothing to do with the ejaculation. Basically, the ejaculation is depending upon the parafollicular area above the varu. So if you are able to preserve a centimeter of length above the varu, you will be able to preserve the ejaculation. And it has been.
Have you seen in enucleation when you have done that, they are doing ejaculation?
Sometime, yes. So when
I feel none of the patients after TURP and enucleation, whatever the format, they don't get semen at all.
No, sir. Actually, if you are preserving the varu, the hood, I have few patients. So whenever I am doing an ejaculation preserving enucleation, usually what we will say is that around 60% may have a ejaculation preserving.
First of all, the prostate produces 90% of the semen. And if only semen is, prostate is out, only one drop will be there from the testicles.
No, the seminal vesicles also.
Yeah, there are storage organs primarily.
Yeah. So basically the ejaculation, sir, it is still there. It may be dry in a patient who is very old. I have seen that patients have this.
This is what I am thinking every time, that if you do TURP, not a drop comes. And you can't say it is retrograde ejaculation, because 90% of the semen volume comes from the prostate and you are doing complete removal of prostate. Where is this concept of parafollicular, above the varu?
Sir, actually, see, the fact is this, that what happens after a TURP is that if you are resecting near the varu becomes retroverted. So with a retroverted varu, the semen is going to go back. So that is, it has nothing to do with the bladder neck. It has been found that patients who have an open bladder neck after a spinal injury, they still ejaculate. So the concept basically has changed, and there are studies which are very old also. 1995, 96 literature is there. So we need to be taught the way it is. We are taught that bladder neck incision will make you infertile or will cause a retrograde ejaculation. That's a wrong concept.
But also, I have seen many of the patients who undergo TURP, if they are having potency, they lose it 50% of the cases somehow.
Sir, the fact is that you need to have the questionnaire. So basically, whether
I had a little bit in the early part of my career.
so basically,
Wherever monopolar TURP or bipolar TURP you do, I mean, I'm not documented. I am not, this is not the correct way of telling, but some amount of erectile dysfunction will be there in them.
sir, it is documented around 30% of the patients
Yeah,
of
yeah.
BPH will have a erectile dysfunction also, which may worsen after the procedure.
Yeah, yeah. If post Urolift or Rezum, if you want to TURP, any clinical experience anybody has in India or outside, will it be okay, easy, no problem?
Sir, it will be easy. This is what I said, that you can enucleate them easily. And the only thing is that when you are morcellating, you need to pick those clips out. Otherwise, your morcellator blade will go. So you need to pick up those titanium. So in a TURP, there should not be any problem. You can chip it easily.
Why morcellator cannot break the clips?
No, sir, they are titanium clips. So your morcellator blade will actually get lost if you are doing that. So you need to remove that before you are doing the morcellation.
We have to see a TURP after Rezum. That will be interesting when we are doing it, what happens inside, whether it forms a cavity, whether it forms fibrosis, whether it shrinks cells, how it.
It is actually too early to say. Usually the patients are very. I was thinking of doing a scopy in these patients. Maybe next 6 months we will have an answer to it.
Yeah, scopy, not only that, and in patients with retention post 70 years, and they are not very fit and they don't want surgery, they are ideal indications. But that amount of cost, whether they can put or not, is the only concern. If the cost is less, yes, it can be tried for many patients, and if fails also, we don't lose anything. So, as you said, the RIRS, the robotic surgeries are coming to sooner at very, very low cost. These two also may change its shape, and then we may have advantages. Meanwhile, at the moment, you have to be choosy because TURP and enucleation are very good at their results. So unless we are choosing, I think youngsters with small volume prostate who wants to preserve ejaculation and doesn't want to use medicine is one indication. Catheterization followed by retention, which is not relieving, and patient is unfit for any surgery, is the second patient, especially CAD aspirin. These two becomes absolute, relatively absolute indications for anyway. Good that you have done both, and good that you are in Delhi. That's why good that you are prostates more surgeon and people are approaching you companies. A lot of them they approach somehow. I could not mobilize the cases because of fear that what will happen. Even if they are reducing the cost for initial 2-3 cases, I could not mobilize because of fear only. That if it fails, what happens? If it fails, what happens? Anyway, local anesthesia, if somebody is giving free of cost, we can try initially. There is no harm. Maximum it will fail. That's all.
Correct.
Am I correct with my understanding?
Yes, sir.
Yeah. So with this, we conclude the session. Thank you very much. But you have put a lot of effort in the slides. It is looking like I don't know how you put a lot of effort. Whether for this already you might have done presentations. Excellent.
Actually,
I'm very happy that
I did one of the Urolift presentations. Then this Rezum we added on the slides of Rezum because comparison was not there. So
great. Highly appreciate it. This is what exactly I wanted because everybody is showing the procedure. Every state one person is doing. I'm seeing the Facebook. I have done Rezum. They are injecting. They are very technically less demanding procedures. All you
Yes,
have to
so
do is
basically that is the thing. I think Rezum, it may become popular because anybody can do it.
yeah, maybe it may go into the non-urology hand also. I'm doubtful.
Yes,
That's a little, because any rich person can buy and then put into the prostate. He may get or may not get the result, but he'll finish the procedure.
correct.
So it's concern. We have to see the future. Anyway, debatable. Good if it is minimally invasive and give something best to the patient. Very good. Thank you
Thank you, sir.
for taking it unlearning and relearning, especially top class enucleation surgeon doing this minimally invasive. Great.